Right, we are live, ma'am.
Yeah. Good evening, everyone. Welcome to yet another session on laparoscopic hysterectomy. So this session was requested by a few of gynecologists who wanted to know as to what steps are different in a uterus which is bigger than 12-week size. So this class will give you tips on how to actually manipulate or how to standardize your steps, not depending on the size of the uterus. So many of us have this question, where to put the port, how do we remove the specimen, or do we have to do uterine artery at origin, or how do we do the bladder dissection, what are the precautions that we need to take care, until what size of the uterus should we accept, or when should we open, and how to counsel the patient for ureteric injuries or any complications of usually hemorrhage in such large uteruses, which are because of either fibroids or because of adenomyosis. So I will let Dr. Jay speak for 10 minutes, and then probably we can have a discussion for 2-3 minutes, so that the simpler questions which he might not be able to speak on his own maybe can be answered with my questions. Yeah, please, over to you.
Okay, so I have actually shown videos of this very recently. 32-week uterus, how do you remove it? And I've shown it live on YouTube, the entire procedure, right from entering the port till removing everything. And that was a 32-week uterus with ventrofixation. The whole uterus was fixed to the anterior abdominal wall. Correct. So I probably want to just drive home one important point, that the limitation is in our mind. The limitation is not there as far as doing surgery is concerned. Okay. So anybody who is trying to say, and according to me, I had recently met one of the girls who was exam going, and the examiner scolded that girl, because when she answered in her exam, and this is a true story because it happened in my OT, that girl had come to get operation done for her mother. And when she goes for the exam, she was asked that what is your size cutoff criteria for doing total laparoscopic hysterectomy? And this girl answered there is no size criteria. Okay, and the examiner scolded him. Okay, why should an examiner scold a girl for answering the truth? Okay, according to me, that stupid examiner should be scolded, because the answer which was told to the girl was anything more than 12 weeks. Okay, you should give the patient an option of abdominal hysterectomy. I think that person's phone should be taken away and he should be handed back Nokia 1100. If somebody answers like this in life. See, we are in
No, see,
2025.
it is not like
Okay.
that. Let me
No,
just
no, 2 minutes. No,
no,
your chance is
no,
not there.
no, 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 no. I think your expertise and your level of competence is way, 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 different than 99.99% of the gynecologists. So I think we should be more relatable in these kind of classes, where I understand. I mean, you do 36 weeks uterus in 10 minutes and 32 weeks in 9.5 minutes. All those things are fine. But see, when in a standardized teaching programs, what happens is they want the safety comes first. And then is how adventurous you can actually be in terms of taking up the cases. So because I see so many of the complications done by beginners or even people who are trying to still master the art of laparoscopic hysterectomies. How many ureteric reimplantations you do in our place? I mean, we know it. That is the gynecologist who refer it to us after they have done hysterectomies. So I think the competence level and also the confidence level of the gynecologist is something which we should take into account before actually we go ahead and tell them you can do any size of the uterus, and they struggle for 6 hours. I have seen with my own eyes a person struggling for 6 hours to remove a 16-week uterus. So I mean, there are lots of debatable points in all this, but I request you to keep it a little to our level, where we can actually try and take home the learning points from you. I understand you can remove even the tonsil through the vagina, but I request you to be a little more. Sorry, yeah, please.
Wow. Okay. So no, so coming back. Okay. See, one, in a routine situation, I don't think you should keep the port positions very high. If the uterus is, let's say, 30 weeks, don't keep the port on xiphostermin. Don't do
Mm.
that. I've had 3 patients in whom I have repaired stomach so far because the trocar has gone through the stomach, anterior wall, through the stomach, posterior wall. Full hysterectomy has been finished. Okay. Trocar has been taken out. Doctor went
Great.
home, but patient did not went home. Okay. See, immediately post-surgical. See, the good thing about the stomach is no stomach has lot of acidity. So what is going to happen is no, the minute you give water to the patient, there will be full abdominal distension in a situation like this. Okay, so it's a very scary situation. Huh? Anterior posterior perforation. It's like doing laparoscopic hysterectomy with bariatric surgery, because in bariatric surgery you are cutting the stomach. No, so something like that happens, and then you have to staple the stomach. So we have done that 3 times already in our situation because the trocar was kept at xiphostomy. Okay, keep this in mind. Very important point. Go where your normal trocar is. That means supraumbilical. So the first question is why? The answer is very simple. No matter where the fundus of the uterus is, IP ligament is at IP ligament, and uterine artery still comes from anterior division of internal iliac artery only, which is deep down in the pelvis. Okay. So if in case you have to devascularize that uterus, let's say you convert open to laparotomy, I mean laparoscopy to laparotomy, the most important thing is devascularization. Correct. In devascularization, internal iliac is deep down. So remember, your port position should be such that you can go and coagulate the internal iliac artery at its origin. Basically, uterine artery at its origin. That's a very important thing. In any large uterus, let's assume 16, 20, 25, 30, 40, whatever weeks it is, the first step should be to go and coagulate the uterine artery. Okay, because it will automatically devascularize 50-70% of that uterus for you. What it does is, once the uterus is so devascularized, no, you are never worried about bleeding. You are never worried about venous bleeding. Artery is not going to be very heavy because artery always coagulate the artery at origin. In large uterus, do not go to that routine like standard hysterectomy where you have 2 millimeter artery and you are coagulating at the genu or at the lower segment. Don't do that. Coagulate it at the origin and cut it from the origin. Once you do that, uterus will be devascularized, uterine vein will collapse. Normally, in a large uterus, the uterine vein will be very large. Okay, that uterine vein will completely collapse once bilateral internal iliac arteries have been cut. Basically, bilateral uterine arteries have been cut. So that is something which you should follow. That's a very, very important take-home point to do your surgeries rapidly. Understanding? The second important thing in this situation is always dissect the UV fold the first, because that is the thing which is visible to you in front of your eyes. Okay, dissect it first. No need to worry about this. See, one great thing will happen when you open the uterine artery. I mean, when you cut the uterine artery. Okay, automatically underneath that will be the ureter. Okay, so above the ureter is the posterior leaf of the broad ligament. So you don't have to lift the uterus. You don't have to struggle in lifting the uterus at all. Lifting the uterus out of the pelvis. Just open that and cut the uterus across both the sides. Correct. Once that is done, only thing which is remaining is IP ligament. Don't cut the IP ligament immediately. Keep it for stabilization purposes so that the uterus does not wobble inside the pelvis. Keep it for stabilization purposes and cut the IP ligament in the end. And then go and open the vault and just remove the specimen by doing a standard vertical colpotomy. Do not struggle with that tiny colpotomy of 3 centimeters to remove 30 centimeters of uterus. Convert that 3 centimeters into a 10 centimeter colpotomy by doing a vertical colpotomy, and please extract the uterus from there. Your uterus extraction time, I think we have shown this. Okay, this is why I'm telling this. Very recently, we showed this entire surgery on YouTube where after removal of the uterus, we close the vagina and everything for a ventrofixed uterus finished in 45 minutes or I think 50 minutes. I don't know how much what is, but it finished in that much time. Okay, in all these things, your mental fatigue will be very less. In all these things, your arm fatigue will be very less, and you will be able to do 5 more surgeries like that in a single day. Otherwise, like how Shilpa madam said, that if you are going to be struggling with this, then you may do that only as one case for the day, and then you will feel in the fatigue and you may want to go home and sleep. So don't let that happen to you. The second important thing, medico-legally, I want to tell you very explicitly that there is no guideline which states that beyond this, you should not do this to the uterus. Okay. There is no guideline which states that 13 centimeter uterus can be removed with laparotomy only. No, there is no such guideline. Okay. So please don't get worried what is the guideline saying. And ultimately, remember, guidelines are made by human beings. Guidelines are made by people who don't operate. So please, for God's sake, don't end up following or even considering guidelines like this, because there are no guidelines to this. Okay. Now, third, very importantly, almost all the time people is going to ask this question: what if there is sarcoma in such a large uterus? Okay. Remember one thing: if there is sarcoma, the minute you put your trocar, you will know it is sarcoma. You will really never struggle in that situation. You will know it is sarcoma, convert it into laparotomy, midline vertical, TLH, BSO, lymphadenectomy, omentectomy, whatever is to be done, please do it and finish. Don't think at that point in time. You have to do it laparotomy only at this moment. As far as the guidelines are concerned, don't think about it under any situation. Okay. Now, क्या बोलते हैं, very important sort of a tip when it comes to dissection of very large uterus. Okay. See, I don't use uterine manipulator. And remember one thing: in large uterus, uterine manipulator will not work. Okay. If the size of the uterus is 18-20 weeks, no, your manipulator is going to be bakwas. It will not work in beyond that size of the uterus. है ना? So remember, instead of using that delicate and cute graspers, the bowel graspers which people use to mobilize the uterus here there, use tough needle holders, strong needle holders to do mobilization of the uterus and manipulation of the uterus. I do not prefer to use myoma screw. My training has never taught me to use myoma screw anywhere, because myoma screw causes a lot of bleeding and it creates a lot of holes along the surface of the serosa. So because I'm trained by Dr. Ashwath, who does a lot of oncosurgery, we follow a no touch technique over the serosa. So what normally happens is, I'm very used to holding the peritoneum. I'm very used to holding the broad ligament and round ligament and manipulating the uterus. And I think Shilpa madam or anybody of you who has seen me operate ever will agree that I do it very frequently in that manner only. Okay. Probably try to learn that technique in a large uterus. It will really, really be of very much helpful to you. Okay. One more final point. If you are a beginner, do not fall prey to anything like ipsilateral only, contralateral only, this only, that only. I'll give you an example. Okay. If you are doing ipsilateral, how will you approach the uterine at the opposite end? Let's say if you are doing ipsilateral, I'm a lefty. So let's assume I'm doing ipsilateral from left side of the patient's abdomen. How will you approach uterine artery and on the opposite end in such a large uterus? You will not be able to approach. Understanding? There is no shamefulness in putting two ipsilateral ports on left side and two ipsilateral ports on the right side. Any which way they are 5 ports. So it is going to make your life very easy in large uteruses, that one extra fourth port. Never ever forget to do that, because many people is very used to doing ipsilateral, and in ipsilateral they are having a very much struggle when it comes to coagulating the uterine on the opposite side. Bindas put two 5 ports instead of one. No, you're putting two. What is the big problem in that? I think it is absolutely no problem for you or for anybody in that matter to put in that particular manner. Okay. Now, I mentioned one very critical point, that uterine artery to be cut at the origin. Okay. The reason why I mentioned this as a very important point is because in large uterus, the vein is going to be so large that it is going to cover the entire uterine artery. Matlab, it is going to be overshadowing the uterine artery. And if you do not coagulate that, many a times you would see that the vein will bleed. The minute you take that first cut, the vein will start bleeding from inside. And then, of course, everybody is going to be in a panic that why is the vein bleeding? It has never bled like this. It is never my hands, this, that, whatever. That's the reason. Please follow that point of making the uterine artery cut at its origin. Cut, huh? Not coagulate. Cut or clip. Whatever you want to do, you do. Okay. Okay. One more very important point. Anatomy will be grossly distorted, but anatomy is going to be good only in the lateral aspect of the pelvis. That is why we have taught in so many situations round ligament to be cut as laterally as you can. Infundibulopelvic to be cut at the sacral promontory, right? We have shown it in our videos. Kindly follow only that, because only at that position the anatomy is going to be normal. Understanding? I will give you one more example. See, I don't know the English word. I've tried to do it so many times in a large gravid uterus, doing uh, emergency cerclage. Correct. You have seen, no? Large gravid uterus emergency cerclage. No patient is first. Correct. What you are doing in that? You are creating window. You are passing your stitches through, matlab median artery. Correct, no? Here also in large uterus, gravid uterus is large uterus, no? 20 weeks, 24 weeks, it is large uterus. Are you putting uterine manipulator in gravid uterus? You are not putting. Correct? No, because baby is going to be present inside. In that situation, how you are manipulating? No manipulation. Still cerclage is happening. Still cerclage is going at the internal os. So take home this point. Create that window, same like how you do it in pregnancy cerclage. First, finish off the vasculature everywhere. Automatically, that uterus will become so beautifully devascularized. You check any of my videos, we follow the same technique for all those cases. And ask to Shilpa madam, our large hysterectomy will finish in 5-10 minutes, 7 minutes maximum, because uterine artery is uterine artery only, bladder is bladder only, round ligament is round ligament only. It is just that in our mind we are having a fear that it is a very big uterus. Today I have to remove, cut, make that necklace and post it in one of my groups so that other people will clap. No need to do all that. Okay, beyond a point in time, very important to follow the same principles every time you do a large uterus. And when you consistently do the same principles, your journey will be very smooth. My anesthetist has a habit of always reserving uh, 2 pints of blood. Okay, whenever we are handling a uterus which is more than 18 centimeters in size, and that is a blanket rule in the hospital. We do not compromise on that rule at all, because I personally think at that moment to consider happiness of the family and safety of the family is also very important, because they will be very happy if blood is reserved in case, just in case anything untoward happens. Okay, with this I am concluding, and I will be happy to answer Shilpa madam questions.
Yeah. So I had a couple of questions. So always we talk about speed in your surgeries, and many people always ask that whether speed is so important, isn't the safety. So the only thing is, like, see, I see that you have mastered these techniques so well.
So I will answer that question in a very simple manner. If you can write down on a 500 rupees stamp paper and give it to me, that if you take 6 hours for doing a hysterectomy, you will not create a fistula, I am willing to change my statement. Understanding? So for all people, just because just because we have the ability to speak, that does not really mean that we speak on every subject. Okay. If in case you do not have the adequate expertise, it is important to get trained. It is important to watch other people's surgeries. Many of them are available on social media, and learn the fine points from all of them. If you follow standardized surgical steps, okay, and even if you have a broken hand and a broken leg, correct, then also you will finish the surgery on time. Just remember that finishing the surgery on time is a matter of dissection and surgical principles. It is not a
Correct.
matter of trying to do something or not trying to do something. So
I totally.
basically, I personally think that argument that, oh, he is finishing on time. Okay, how can you? I mean, Bangalore to Bombay flight is 2 hours 20 minutes. Just because the pilot took 24 hours, that does not make the flight safer. Okay, that you are not trying to count in the risk of anesthesia, risk of head low, the risk of every other thing which you are associating with a prolonged surgery. So I personally think one must give importance to doing the correct surgical technique. If you by mistake do the correct surgical technique all the time, you will finish the surgeries on time. Correct?
Yeah. So when we are talking about large uteruses, so the first
Yeah.
thing that you always tell is the uterine, the
At
coagulation
origin.
origin. So you think everybody should be well versed with retroperitoneal
In
anatomy?
large uterus, yes. Because remember one thing. See, you cannot say that I don't open the retroperitoneum. Correct? Then by that logic, do not do large uterus hysterectomy also. Because what do you do in an emergency situation, madam, in obstetrics? You do internal iliac ligation. Correct? Do you open the retroperitoneum in that? You
Yeah.
do. Correct? You can't approach the internal iliac without opening the retroperitoneum. So
But
it is
many
a
people will
core.
not be able to do intrailiac by themselves. See, that is the point. See, in laparoscopic hysterectomies, the step by step, the skill sets that they acquire is first to do the hysterectomy. I mean, then they suture the vault through the vagina in the beginning. Then they learn endosuturing, which will take them a couple of weeks or to couple of months. And then they learn the retroperitoneal. Retroperitoneum is an advanced thing that actually, like, it will require a lot of I think mind management to start doing going to that level, because they have their own apprehensions, which I totally understand. So these are the levels. So you're saying, like, beyond which size of the uterus that they should do the uterine artery at origin.
No, no. According to me, when you are learning, take help of, let's say, one of your colleagues who is adapting laparoscopic surgery, and make sure that when you are taking help of one of your colleagues in very simple cases, you end up doing uterine at origin. That will give you the sort of, that will give you an expertise as to how do you end up doing these types of surgeries and how do you end up reaching uterine artery at origin.
Mm.
Once you have learned that in 10-15 cases, even in bad cases, you will be able to reach there. Reaching the
Mm.
uterine at origin is again a matter of dissection. It is not a matter of anything else. It is confidence, basically. It has got nothing to do with anatomy. The uterine does not know it is there.
Yeah,
We
yeah,
are the ones who have created these landmarks. Okay.
yeah. So in large uteruses, so what are the common complications that you have seen? Is it bleeding, which is more common, ureteric injuries, or is it like, bladder injuries, or what is it?
Uh, Honestly, I'll tell you, madam, nothing happens in a large uterus. Honestly, very honestly. I'll tell you the
Mm.
reason also why. See, majority of the injuries happen in a very simple cases. When the case is so tough, no, you are already vigilant about everything in life.
Correct,
Usually, the risk of having an injury in a large uterus is very limited. Trust
correct,
me, it is
correct.
very limited.
I
It's
agree.
only it's only going to happen, madam, if we are attempting something matlab, out of the planet. Like for
Yeah.
example, you are attempting vaginal hysterectomy for 32-week uterus. Something like that. This is unscientific stuff. If you do something like that, uh, then it's a different story.
Yeah, yeah. So in this talk that you mentioned, I think the important factor is like, doing that inverted T colpotomy where you extend the colpotomy, like, vaginal opening, and then you remove the specimen because the injury to the vault will be very less, and then the vault hematomas will be less, and pulling, pushing, the time taken for specimen retrieval also will be quite less in such cases. So in
Yeah,
these situations, I mean, have you noticed that like, there could be because you dissect a lot of rectum deep down there and you push it so that there is no rectal injury. So you think in such cases, like, the rectal injury can happen if we are not adept in identifying the spaces and
correct. It can happen because you will cut straight in the rectum, no?
hmm, hmm, hmm.
So in
And
that
some.
situation, it can happen.
Yeah. So in these large uteruses that you are saying, so if the uterus is enlarged transversely,
Yeah,
rather than vertically. Vertically, I think it is easier for us because it is like, simple, straightforward. It is just about like, couple of more steps where you have to coagulate and cut. But in a transversely enlarged uteruses, so what is it that because the vision is something which will be a little challenging when you're trying to like, see, and if you don't have good assistants, you kind of like tend to kind of like, get delayed because you're trying to achieve the optimal vision. So in such situations, you think 3D is better? Like, does it really make a difference in terms of like the vision?
3D is probably the gold standard for the pelvis. I mean, for any case.
Yeah, I
Routine
agree.
ischemocele also 3D is good, in my
Yeah,
opinion.
yeah.
Correct? I personally think there is no argument to this. I mean,
Mm,
I've stopped arguing with people who are still on that, shall we use 2D or 3D and all this. I mean,
correct.
I've been on 3D since 8 years now. So I
Yeah,
have not the last time I did a 2D case was in your hospital in the first visit in Bangalore when
yeah.
we had
It's
done those two
okay.
fistulas.
Yeah,
Remember?
you don't have
So
to be
after
insulting. It's fine.
no, no, it's not that. What I'm trying to tell you is that after that, see, we have also not done a single 2D case in Bangalore also, madam. So it makes a big difference according to me.
I know, I know. So equipments, vision, and also assistance, I think all this have a lot to play as a role in terms of like, achieving that kind of the finesse or that confidence when you do large uteruses. So finally, I don't think you would be the right person to give a take-home message. But whatever in my journey that I have learned, I do up till like, 26 weeks size uterus, TLH, and above that, as usual, I hand it over to you in a platter. So till then, I think it requires a lot of one. You need to watch a lot of videos, and you need to, like, understand as to what are your strengths and your weaknesses, so that you can have good assistance, good vision, good camera, and good instruments most of all. And you should be adept in doing the retroperitoneum and also the rectal dissection if required, if it is in a previous section cases. But other than that, I think big uteruses are much more easier to operate than the normal size uterus or postmenopausal uterus. So I thank each one of you for joining this class. And I thank Dr. Jay for coming here and telling us that we are not good enough. But thank you any which ways. Thank you for coming.
Hey,
Bye.
come on.